TopMedTalk.
Paul Wischmeyer, and he's an anesthesiologist and critical care physician and friend of the TopMedTalk family. Paul, thank you so much for joining us.
Thanks for having me. It's good to be here and glad we can talk about such an important topic.
Paul, I know you mentioned that you're on the nutrition team as well, and I know that's something that you're very passionate about. We've heard just a very little bit come out about ways in which we can kind of protect ourselves through nutrition and optimization of our personal being. Yep. And so I want to talk to you about that, but I also want to discuss about what we're thinking about, how we're going to deal with nutrition and optimization for our COVID patients that are on not long-term ventilation, but up to a week in being on the ventilator. So can you speak a little bit to that?
Taking the first question first, when you start to think about how we can protect ourselves, we have some reasonably robust literature for a few interventions that we can do in the community that do seem to associate with prevention of viral infections. Oh. And so I think the first would be maintaining a normal vitamin D level. There's large population studies, 20,000 plus patients, where they look at risk of influenza and other viral transmission of upper respiratory and lower respiratory infections. People that have low vitamin D levels have significantly more, in many studies, viral infections. And the mechanism and pathophysiology of that, it makes a lot of sense. Vitamin D is essential for immune surveillance in the lung. It makes cathepsin, which is the macrophage factor that helps kill things in the lung. It's essential to immune function, especially in the lung. And so I'd advise everybody to take 2,000 to 4,000 of vitamin D3 every day, and make sure my kids are taking it, my parents are taking it. I mean, 70% of the country has a low vitamin D level.
Absolutely. It's well known that we all are deficient.
This is a no-brainer, I think. I mean, this is an inexpensive, safe thing that everybody can do to improve their immune response against the viral infections. There aren't a lot of treatment trials with vitamin D yet in this, so I can't give you a lot of direct treatment evidence for randomized trials in that area, but a lot of that's because those studies just haven't really been effectively done yet. But we do know that people with low vitamin D levels have a much higher preponderance of getting viral respiratory infections. And so I think that's something you can do for your family. The other thing where we do have direct evidence, even at the very highest level, there's a publication in Nature, actually, not Nature Medicine, but Nature. It shows that taking a probiotic, a lactobacillus probiotic, can significantly prevent somewhere between 30 and 40% reduction lower respiratory tract infections like COVID would be. So there was a large trial done by a U.S. investigator who I've had the chance to get to know pretty well, where they looked at 4,000 full-term well babies in India, and they randomized them to a lactobacillus probiotic with a prebiotic, which is some fiber with it, or a placebo. And there was a significant reduction in pneumonias, sepsis, lower respiratory tract infections, dramatic effect in the individuals who took the probiotic. And so, again, this is a safe, cheap.
Yeah, everybody can find it anywhere.
The actual mechanism he described in his discussion as to why they chose to do this study goes back to some of the work my lab did. Actually, he cited our laboratory's research where we studied lactobacillus and its ability to prevent ARDS and prevent pneumonias. We were doing pneumonia studies 5-6 years ago where just taking lactobacillus orally can really prevent dramatically the infections. It affects T-cell populations in the lung, improves clearance of pathogens from your lung, production of mucins that help clear them. I think the lactobacillus GG that's in Culturelle, that's in everybody's grocery store. I don't work for Culturelle and don't have any relationship with them, but all my family and all my kids and myself are taking Culturelle. And in fact, I just sent some from Amazon to my kids last night to take. And so everybody can do that. I think one capsule of regular old Culturelle lactobacillus GG has robust evidence. There's actually 3 large meta-analyses that show it prevents viral infections and other respiratory infections as well. Cochrane has one. There's a 10,000 patient one in one of their British journals. So there's thousands of patients studied in this area. We're actually thinking about designing a trial at DCRI here at Duke where we might give healthcare workers this in a randomized controlled trial as a prophylaxis against it. I'm working with one of the DCRI clinical researchers who's trying to set up a platform to collect data in healthcare workers.
Fantastic. Okay, two questions. One, what is the strength of it? Because, there's probiotics and then there are some probiotics.
Yeah. So, for instance, and I'm gonna use Culturelle because it's something I know people can find in the store. And again, I don't have any commercial relationship with them at all, but it's what I take. And the regular strength Culturelle, not the double strength, should be sufficient for what we know about at least the treatment that's been given. Culturelle is the product that actually was used in an NIH trial of probiotics to prevent ventilator-associated pneumonia, and it reduced ventilator-associated pneumonia by half.
Gotcha.
50%. Yeah, it was in a Blue Journal publication, so in a very high-level, high impact factor publication again. So there's really robust evidence for this. And so I think the routine Culturelle, there also are versions that have a little prebiotic, and I think that's actually probably preferable or good because that's what the actual Nature paper, the big high impact paper in Nature did. So I think the regular strength Culturelle, Lactobacillus GG is what was used. The Nature paper actually used plantarum, but I don't know a lot of plantarum products. Lactobacillus plantarum is another strain. But all our research was with GG. The lactobacilli seem to have the most evidence, at least mechanistically.
And I think that the prebiotic, isn't that what the probiotics kind of feed off of too? I mean, it's the fiber. Yeah. Okay, my second question, and this kind of goes back to what we could possibly be dealing with some of these COVID patients, and I'm maybe way out of date on this, is probiotics with septic patients. Is there anything, was that an issue?
Yeah. No, actually, I published the meta-analysis with a group I work with looking at the use of probiotics in the ICU.
Yes.
Robust evidence in a few thousand patients now, multiple studies, of course, showing you can reduce infections with probiotics in septic patients as well. Or not septic patients, but ICU patients broadly. I guess they weren't all sepsis studies, but in ICU patients broadly. And so the use of them, particularly, say, to prevent subsequent bacterial pneumonias on top of perhaps the COVID they come in with, could be quite effective. There was a large trial the NIH funded, or reasonably large trial the NIH funded at Creighton K Award, where they again showed a reduction of ventilator-associated pneumonia by 50%. In patients, they smeared a capsule in the mouth to treat the oral microbiome, and they had them swallow a capsule down the feeding tube that they had in G-tubes. Yeah. And that was a highly effective. In the intention to treat group, there was a 50% reduction in subsequent pneumonias in ventilated patients.
Fantastic to know. That is awesome. Well, Paul, is there anything else that you would tell us as, the healthcare workers or, someone sitting at home, what else we could do? So you said vitamin D, probiotics, anything else?
There's some reasonable evidence, at least in the burn world, that if you do get COVID and you have lung leak, right? And we think lung leak is part of what happens. There's fairly robust evidence that taking a fair dose of vitamin C, like the emergency, more than 1,000 milligrams a couple times a day, reduces the vascular leak. In animal models, it does it in sepsis, and it in the burn world, right? When a patient gets an inhalation injury and they have a lung leak, vitamin C markedly reduces the amount of fluid they need in the leak they see. It's really impressive what it can do to seal a lung leak, and so it wouldn't hurt. I think you'll actually feel less symptoms too. We know vitamin C seems to reduce the symptomatic nature of viral infections. And we don't understand this COVID disease really well yet, but it does seem to have some relationship to giving good diuresis and fluid management. Some of that hypoxia you feel may be lung leak, and the vitamin C may help feel better. I'm not advocating that we have enough evidence to say it will treat it per se, but you may feel better because of that reduction in lung leak that we know we see in the burn unit from taking a little extra vitamin C. And so I think that might be a reasonable choice for some people if you are diagnosed with it and you don't feel well, like you feel that shortness of breath. Not to say you shouldn't go to the hospital, but if you do stay at home and you feel well enough to do that, that's an option I think you could also take. What
we've been hearing is that putting people on ventilators because they are on COVID, it's that single lung or single organ failure, but we're also seeing a lot of acute kidney injury because we're not managing fluids well, nutrition deficiencies, liver issues. I mean, there's all kinds of crazy stuff that's happening that are not necessarily typical of a septic looking patient, from a viral lung.
I think, these are patients we should be able to feed early. They don't coming in with, like you said, multi-system organ failure. That I think this really will give us a chance to really focus in on some of those other aspects of ICU care that promote recovery. These are people that can be walking on ventilators. These are people that can be fed early. These are going to be many young, healthy people that we should be mobilizing and feeding and doing all the recovery things the minute they get in the hospital. Really, truly what's unique about care of these patients, this is a very different kind of patient that we're going to see that is the perfect amenable patient to early mobilization, the perfect patient to early feeding, the perfect patient for all the rehabilitative things that we sort of are challenged by in the really multi-organ failure patient that was hard to do. That should not be the case here.
Yeah. I mean, that's the only way we're going to get these patients off these vents and get them well and recovering, for sure.
Work and back to their lives.
Yeah, absolutely. And then, Paul, from a critical care side of things, when we're taking care of patients that are, that we actually end up having to do more interventions, either if it's, intense CPAP therapy or we escalate up to a true ventilatory support, what would you suggest that we do? Because, some of these patients are on the ventilator for, 5 to 7, if not longer days. They may get off of it. Their likelihood of getting off the vent is actually, or extubated is higher. But what would you say as far as nutritional support and optimization for them?
Yeah, so I think we're excited to even really study that. I think we know so little right now. We just got approval from the Duke Research Office to submit a trial that we're going to do using some really innovative instruments to really study how to feed and what happens metabolically to these patients. We have a study looking at the cardiac and metabolic pathophysiology longitudinally from hospital admission all the way to discharge, starting in the ICU, of COVID patients. It's at the IRB now. They're doing an expedited review on it. We hope to hear back any day and be able to start, we hope, within the next few days, where we have a brand new metabolic cart that is a portable, rapidly calibrating metabolic cart that we've been studying at Duke. We have the only instrument in the United States. There's only 7 clinically operating instruments of this in the world right now, and we have the only one in the U.S. that we're excited about. We're going to start doing daily or every other day metabolic carts. One of the neat sets of data this gives us is not only how much do you need to feed this patient, but we can get in non-invasively measured cardiac output from the Fick equation, because we get VO2 and VCO2. So one of the complications that Seattle saw a lot of was this acute heart failure that these patients get with COVID, and it can happen after the respiratory symptoms have improved. And so this is a non-invasive way to measure cardiac output using these devices. And now this is FDA approved as of a month ago and commercially available in the US. So this is a really nice monitor to measure cardiac output non-invasively, and also to guide energy and calorie and delivery and energy needs in these patients that we really know very little about. So we're going to do that longitudinally. We're also going to measure muscle ultrasound using the muscle sound device to give us a sense of what the effect of this is on muscle energy, muscle mass, and muscle quality. And then we're also going to do body composition and extracellular and intercellular fluid. There's a BIA device that we're using that gives us body composition and tells us a lot about the fluid status of the patient, and helps, perhaps maybe will help us guide diuresis. It takes about 5 minutes to do. It's non-invasive. It's a few clips on your hands and feet. It's a sort of a next generation BIA. Mm-hmm. And then we've teamed with a cardiologist, Manesh Patel, and one of our fellows, to add echo measurements onto this layer of every other day measurements that we're going to do from hospital admission in the ICU all the way to hospital discharge to get the true longitudinal cardiac and metabolic physiology of COVID. So we'll get echo measurements that will also assess cardiac output, obviously, blood volume measurements they can do. There's a lot of assessments they can do. And the last piece is we'll actually be able to do non-invasive mitochondrial muscle measurements using a NIRS device. And so we'll have a sense of what the mitochondrial effect of this disease is as well. And we'll have all this longitudinally. So we're just waiting for that trial to be approved. And we're submitting grants now to NIH and to other places to try to help improve funding for this and improve our knowledge and direct care, because this data will be directly available to the caring physicians, right? So this studies like this, I mean, right now all research is suspended at Duke and many other, almost all other institutions around the US that doesn't involve direct patient benefit. Mm-hmm. And it also has to minimize patient and research staff risk.
Yeah.
So this is the kind of trial we're really excited about, because it gives direct patient benefit as it feeds data back on an every other day basis to the clinicians to help care for the patients directly, but also teaches us how to better care for patients in the future who get this. So we have a much better understanding of the physiology, metabolic and cardiac of what's happening to these patients. And so we're really excited to team with a whole bunch of people. We're working with Tony Sung in the oncology world. We've already teamed with him to look at oncology patients using these technologies, working with John Whittle and thinking about how we can bring cardiopulmonary exercise testing in the recovery phase of this, using our in-bed bikes that Amy Pastovar, therapist, studies, and some of her rehab programs she studies. So we're teaming a whole bunch of multidisciplinary people into this to try to think about how we can attack this problem, both at Duke and around the country.
Oh my gosh, I have the chills, Paul. That is just amazing. Well, how fortunate that you guys are kind of in this next wave, where you haven't seen it, that you've been able to prepare for this and that you're going to be able to get that much data from these patients and you have the bandwidth to be able to put these things together, absolutely phenomenal.
I hope so. Yeah, we're really lucky at Duke that we have people like Jerome Mullinger and others that we've brought in, and John Whittle and others that really have expertise in this area that can team with us to really be able to, on the ground, make this happen. I mean, Jerome's going to really be the one that is doing a lot of this in the patient's rooms. And so, in fact, Duke itself has done a great job. They have already built an ICU response research coordinator team of volunteers. Susanna Nagy and Brian Kraft and others in our ICU and in our research office have put together a team of 10, I think there's up to 10 now, volunteers that are willing to do and participate as research coordinators, experienced research coordinators in ICU-based COVID research.
Wow.
They're getting all the PPE training. And Jerome, our coordinator who does the physiology studies, is joining them in the training. And so it's great. Duke has really mobilized the ability to train even our research coordinators to be ready for this outbreak, to get the best opportunity we have to study it.
Well, Paul, thank you so much for joining us, and thank you for sharing your story with our listeners, and really thank you for the service to our patients and our patients that we've been taking care of, because all the work that you've done up until this point has been really impactful for care of the critically ill patient, as well as, anesthesia. And I just can't thank you enough for that. But thank you for everything that you're doing, to advance the care that we potentially could be giving, to the COVID patients and the wave of patients that we may be seeing in the coming months and possibly even years. So thank you so much for that. And I hope you stay safe. I hope you stay well. Keep us up to date, okay?
TopMedTalk.
It's Desiree Chappell here. Just a quick reminder, subscribe to TopMedTalk. We're a daily source of news and conversation focused on perioperative care. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at TopMedTalk.com. That's www.topmedtalk.com.